start. Good morning, everyone. I know so many of you, but let me introduce myself, Mike Stover. I'll serve as your coordinator and introduce the program today. Assisting me is the head of Tier Essentials, Buzz McKeon. He'll be doing the technical aspects as well as taking the questions out of the chat room and reading those. If you want to put in, out of chat, if you have questions you want to do in chat and it comes to you, and you prefer to put it in writing instead of doing it orally when we have our question and answer periods, and there'll be one about every 10 or 15 minutes when we hit a natural spot. When the doctor hits a natural spot in his presentation, he'll just pause, and then we'll open for questions on the content already presented. I'll be moderating today's presentation on dentistry, including implants and periodontal care. Today is part of our transition and retirement series, a topical Saturday morning classes that are open not only to OLLI members, but to the public. We are recording this session. Doctor, that's fine with you?
Oh, yes.
And we will put that on our distance learning website, and we encourage people to view those at their leisure. This class will take between 70 and 90 minutes, depending upon the questions. Let me give you Dr. Clem's background, and then we'll just get on with it. Dr. Don Clem is a board-certified periodontist who has been serving the Fullerton community since 1984, specializing in periodontology, oral plastic surgeon, and periodontal medicine. Originally from Chicago, must be either a White Sox or a Cubs fan. Dr. Clem attended dental school at Loyola University of Chicago and completed his hospital residency at the Great Lakes Naval Regional Medical Center. His specialty training was taken at the University of Texas Health Sciences Center in San Antonio. He has published over 30 articles and 3 textbook chapters. He is a recipient of numerous awards, including outstanding contributions to the field of periodontics from the California Society of Periodontists, and the R. Earl Robinson Award in Regeneration, I assume dental regeneration, the Clinical Research Award from the American Academy of Periodontology. He has the honor of being named this year's recipient of the gold medal for his outstanding work in the field, the highest award given by the Academy. We are very honored and pleased to have him with us. As I said earlier, the Stover family, we seem to tithe for dental work every year. So we're very interested in your presentation. I'm sure the other the members of OLLI and the members of the public who will be with us today and will be with us in the future through the distance learning appreciate you being here.
Appreciate it. Thank you. So I'm going to go ahead and share my screen first of all, see if that whole thing works. And I want to thank OLLI for the opportunity to be with you this morning. I will tell you that your group is really most impressive. When I look, we did this similar program, I think about a year ago in person. And we're going to run this a little differently today. I'm going to stop periodically and see if I can answer some questions along the way. I think at this point in time, we're all looking to get back to normal, get back to our previous life. And I think in this, particularly during this pandemic, the attention to your general health is important. And what I'd like to do this morning is really talk about a very common condition, gum disease or periodontal disease, but really talk about it in terms of more of your general health. And in doing so, we're going to talk about those aspects of what periodontists do, and what is periodontal disease, and what is the periodontium, or what are the gums. And what I hope to leave you with today is the sense that gum disease is more than just gums. So if you look at this cross section that I have of a tooth on the left and the tissues that surround the tooth, you'll see that we have a layer of gum tissue that sort of drapes over the root of the tooth and essentially covers the bone where the tooth is anchored. And it's important to understand that the bone is not directly attached to the tooth. There's a very tiny, small microscopic ligament that attaches the bone to the tooth root surface. And above that bone level is an area of connective tissue fibers that sort of hug the tooth and have further attachment into the tooth root. And then above that is the gum tissue. So what you see in the mirror is your gum tissue. There are really several layers of tissue, many at a microscopic level, that participate in connecting the tooth itself to bone. And it's within this space that we're really going to be focused on today, and what it means for your general health. If you look at a dental film or a radiograph, for example, you will see on the top film that you have a certain bone level. All of this white material is bone, but then you see on the right, you have a sort of valley or an angular, what we would call an angular defect of bone loss. And when we say that a patient has bone loss, what we're really talking about are defects here. And as a result, we have to correct those defects because this cannot be maintained over the long term. Bacterial plaque participates in migrating down the surface, inflammation sets in, and you set up a repeating cycle of inflammation and bone loss. But fortunately, we have the ability to literally rebuild bone around teeth in many instances, and that's what we call regeneration. So one of the things that modern periodontics does is it manages inflammation, and it manages, and in many cases, correct the bone loss that occurs as a result of the bacteria and the inflammation that occurred. In addition, we're also able to reconstruct soft tissue loss. As you see, many of our patients come in with recessions and root surfaces exposed, and you can tell that this is the root surface because it's much yellower than the enamel or the crown, what we would call the crown of the tooth. So how do we reconstruct that? Well, that's possible with different growth factors and different tissues that we use. In managing to reconstruct bone and soft tissue, we can use literally two types of tissues. We can use now banked skin and banked bone from tissue banks in the United States. And one of the fortunate things we have in our healthcare system in living in the United States is that we have perhaps the best bone banking and tissue banking system in the world. And it's an extraordinary gift that patients can receive bone grafts and tissue grafts. Many are involved in trauma, many are involved in severe burn accidents, and we can use this technology to actually reconstruct bone and reconstruct lost tissue around teeth. And of course, when teeth are lost due to advanced gum disease and advanced bone loss, we now have the ability to replace missing teeth with dental implants. And the way that you should think about dental implants is really artificial tooth roots. And those tooth roots can do several things. They can replace a single tooth, they can replace an arch of missing teeth, they can help stabilize full dentures or partial dentures. So there are a variety of ways that we can take advantage of dental implants in terms of improving function. And improving a function and improving how patients chew is extremely important, especially as patients age. And if our goal is to age in the most healthy manner possible, then we should really look to our function and how we chew our food as the first step in digestion. Now, when we start to talk about general health, I always go to Mark Twain. And Mark Twain once said, the only way to keep your health is to eat what you don't want, drink what you don't like, and do what you'd rather not. Now, a certain amount of that is true, but what I hope to convince you of today is that you have much more control of that, and there are other aspects of your health that may be out of your control, and we'll talk about that as our knowledge progresses. Because of that, some patients become fixated on certain aspects of their health. And it's not unusual for me to have patients walk into the office and they have an entire bag of all the gizmos and gadgets that they use on a daily basis in their ritual of keeping their mouth clean and keeping their mouth free of bacterial plaque. I think it can be simpler. We'll talk a little bit about that, but I never argue with success. If this is your routine twice a day, then God bless you all. And the proof is in the pudding. And if you're doing well, that's great. But I think hopefully we will depart from Mark Twain a little bit and make life a little easier and enjoyable for you. So let's talk about health. What constitute healthy gums and bone? Well, if you look at this picture, you can notice several things. First, the gum tissue is pink, and that's what we want to see. We want to see pink gum tissue, and we want to see it well adapted to the teeth with a minimal amount of recession. One of the things that you will find is there's really two types of soft tissue that you will see. One is this pink sort of dense tissue called gum tissue or gingiva. And then you see, if you look closely, a sort of change in color, and it becomes more vascular and more reddened, and it's softer and it's movable. That's mucosa. And mucosa lines your cheeks, the floor of your mouth, your throat, and the inside of your mouth. In addition, you will find that when you're examined by your dentist, and we'll talk about the periodontal examination a little bit, the gum tissue will not bleed. Gum tissue never bleeds. Healthy tissue never bleeds. So one of the fallacies that I often run into in speaking with patients said, yes, I said, do you ever notice your gums bleeding? Oh yes, in the morning, I'll notice blood on my toothbrush because I think I'm brushing too hard. That's really not accurate. With the soft bristle brushes that we have today, with the electric brushes we have today, it's very difficult to impart trauma on gum tissue. And the only way that healthy gum tissue is going to bleed is if you impart trauma to them. However, if you look at this picture, you notice some significant differences. You notice that the tissue immediately around the teeth, called the marginal gingiva or the marginal gum tissue, appears swollen, reddened, and it bleeds very, very easily. And it's very tender. When I try to examine those tissues or I try to manipulate those tissues, they're very tender for the patient. Now, this has generally a couple of different causes. The main or primary cause is bacterial plaque, or bacteria that accumulates over time around your teeth. It can also be influenced by the medications that you take. And many of my patients are on what's called calcium channel blockers as part of their cardiac medications. These are things like Norvasc and other brand name drugs that are calcium channel blockers. One of the side effects of calcium channel blockers, unusually so, is that it sometimes makes gum tissues more susceptible to inflammation And we see this sometimes in our patients. The other thing that happens is that many patients are on anti-inflammatories long-term, and there are dermatologic conditions that occur in the gum tissues that can cause these types of reactions. And we see many patients with quote unquote sensitive tissues or bleeding tissues, and the surface of these tissues can become very tender. We're going to stay focused, however, on periodontal disease, common periodontal disease. So how do we examine for periodontal disease? Well, remember that we said there are some tissues that are attached to tooth root surfaces. And then there are tissues that are not biologically attached to the tooth surface, but adhere to the tooth surface. This is part of the gum tissue. The tissue that is made up of gum tissue is called epithelium. It's a type of skin tissue. And that skin tissue, that specialized type of epithelium, can adhere to tooth surfaces. So I use an instrument called a periodontal probe. And when I probe patients to examine them, I place the probe in that space between the gum tissue and the tooth. And I should not, in health, be able to probe past that adherence of that specialized gum tissue called epithelium. Normally, that's about 3 millimeters underneath the gum line or underneath the gum margin. When we do that, it is, or should be, a painless type of examination, and there should be no bleeding. So some patients will say, well, you know, I go into my dentist or I've seen another periodontist and he's examined my tissues with a probe, and I think they're probing too hard because I get bleeding and it's very tender. Well, this is why you bleed upon probing. If you go back to this photograph on the left, you'll see that this specialized skin tissue that has a space called the gingival space or gingival crevice that is adherent to the tooth. In health, we would probe to the base of this and we would not move into the connective tissue space. In that connective tissue space, that's where the blood vessels and nerves reside. In epithelium or in skin, you don't really have any blood vessels or any nerves. So when I probe in health, I'm probing that where that attachment of that specialized skin is. And because we're not probing into the space that contains nerves and blood vessels, it should not bleed and it should be comfortable. However, in health, you can see that our probe can't get down more than approximately 3, maybe 4 millimeters at the most, and there's really no bleeding on probing. But if you have bone loss, and if you have periodontitis, formerly called pyorrhea, you will find that you can probe past that adherence of the gum tissue into the connective tissue space, and that's where you will have discomfort and bleeding. As you look at the radiographs, then you can sort of start to put this all together. On the left, you have what we would term normal bone level. You can see that we have very standardized bone levels around these teeth. It's more or less what we would say close to normal. And I would expect when I probe and examine this patient, I would have no bleeding on probing, and they would be very comfortable with our examination. As opposed to example on the photograph on the right, let me see if I can get this a little clearer here. So you can see the circled area, I believe, and you will be able to see that particular space has significant amounts of bone loss when you compare it to the photograph on the left. And I would suspect if I would examine this patient that they would have deepened probing depths, they would be very tender and bleeding upon probing. That is how we find periodontitis or periurea or bone loss around patients even before we take a radiograph or even before we take an x-ray. And we can confirm the extent of that bone loss indeed with the radiograph. So as you see now, in disease with bone loss and inflammation, the epithelial attachment or the gum tissue adherence starts to break down with inflammation, and the probe can extend deeper underneath this crevice into this connective tissue, and we have a lot of inflammation and a significant amount of bleeding upon probing. As you can see, this clearly is a case of periodontitis. In this particular patient, that probe reading is 10 millimeters underneath the gum line, when really we expect it to be between 3 and 4 millimeters. But with treatment, with regenerative procedures that we can do, we can regain health around this tissue. We can regain attachment and regain bone. And now we're probing approximately 2 millimeters under the same area. And you can see that the patient now has a nice thickened, healthy area of gum tissue or gingiva that does not bleed on probing, as opposed to what she had prior to treatment. So there is one of the myths that we'll talk about. The first myth that we'll talk about is that you will lose teeth as a consequence of aging. That is absolutely a myth. You do not have to lose teeth as a consequence of aging. We will talk about the significance of age in periodontitis and periodontal disease a little later. When we are able to take these areas and regenerate bone in these sites, what we're really doing is raising the attachment around the tooth surface. We're enhancing the attachment around the tooth surface. And if this is not addressed when the disease is moderate, the more bone loss that you have, the more difficult it is for us to try and regenerate those areas. So yes, if this disease goes on over a number of years and it is not addressed in a definitive manner, as that bone loss becomes more severe, it becomes more difficult for us to resolve. And as a result, indeed, you will lose teeth. So the fallacy is that, well, this is just a common cause of aging. This is a common consequence of aging, when in reality, it's a disease that has either not been treated or not been treated completely, that continues to advance, and it has periods of activity and periods of remission over a number of years. And as a result, if it becomes quite severe after a number of years, yes, indeed, you will lose teeth. And the age is really not necessarily a consequence of the chronologic age of the patient. It's more a consequence of the chronologic age of the disease. So what about, how does gum tissue or how does gum disease affect your overall health? And right now, I'm sure you see little blurbs that periodontal disease is associated with heart disease. Periodontal disease is associated with respiratory disease. Periodontal disease has been associated with arthritis and diabetes. Where does that all come from? Well, what we're really talking about is something called the periodontal systemic link. And in the 1880s, we believed that all disease was linked to three things: bad air, bad blood, and something called bad spirits. It wasn't really until the late 1800s that the germ theory of disease causation was actually formulated by Robert Koch in Germany. He was the first one to show, scientifically and prove, that germs, quote unquote germs, or bacteria can cause disease. Well, what's interesting, working in Robert Koch's lab was actually a dentist who was interested in microbiota, or microbes, or germs, or bacteria. And he became very impressed with Robert Koch's work. And in 1878, a dentist named Miller on the East Coast published a work called The Microbiology of the Human Mouth, the Local and General Diseases They Cause. So this was published in 1880 by Miller, and this started a whole movement of physicians that started to look at the mouth as a focal point of infection. And that's where the concept of quote unquote a dirty mouth came from. Hunter in 1910 bought into this theory. Billings actually bought into the theory of focal infection. And actually the Mayo brothers looked at, in the early 1900s, the possibility of the oral cavity or the mouth as a focal center of disease. And this concept really was pervasive until the 40s. Well, as it started going in the late 30s, it got so far down the line that Cecil and his co-workers looked at 200 cases of rheumatoid arthritis, and they were convinced that rheumatoid arthritis was caused by a focal infection, particularly the tonsils and the teeth. And they looked at 200 cases of patients that had rheumatoid arthritis. They removed, in 46% of them, they removed their tonsils. And in 26% of those cases, of those patients, over 40 of those patients had all of their teeth removed. And unfortunately, neither of those treatments had any effect on rheumatoid arthritis. And with this evidence and more, the mouth unceremoniously became divorced from the rest of the body. Medicine rejected that. Based on these studies and others, by the time we hit the 1940s, actually rejected any connection of dental disease or oral disease with any type of systemic ailment that the patient had. So you see the pendulum swung all the way to the other side. However, it wasn't until the late 80s that we started to see other evidence with regard to periodontitis and periodontal disease and other systemic health conditions. Mattia published a very interesting work in the British Medical Journal and showed that there was a significant association between patients that had untreated periodontitis, root canal infections, and the incidence of heart attacks. It was independent of other risk factors such as smoking, cholesterol levels, and obesity. Periodontitis or untreated root canal infections were an independent risk factor for patients having heart attacks. And later, as late as the early 2000s, Hubble and his co-workers showed that individuals with periodontitis had a surface area that was infected underneath the gum tissue and inflammation equal to anywhere between 8 and 20 square centimeters. So what does that equate to? That equates to the palms of your hand. So if you would go to your physician and the palms of your hands were bleeding, highly inflamed, and infected, you would be very, very concerned. But if you take that same surface area with the same level of infection and inflammation, and it's now hidden underneath the gum tissue and has very little in the terms of symptoms, it's ignored. And indeed, we have to ask this question: have patients, physicians, dentists, and periodontists for that matter, minimize the significance of periodontal inflammation with regard to overall health and well-being? So continuing with this line of thinking, as more and more evidence came out in large, what's called epidemiologic studies, meaning studies that look at large populations of patients. Patients with high bone loss scores, meaning they've had a lot of periodontitis, either in the past or presently, had twice the incidence of coronary heart disease and 3 times the odds of developing stroke. And you have to ask yourself, what is this relationship? what is the relationship between periodontitis and these systemic health findings that are increasing? Well, we have to look at two things. Remember, we talked about gingivitis, and gingivitis is highlighted by gum tissue inflammation, which is caused by bacteria primarily. We can have inflammation in the gum tissue that is secondary to some of the medications that patients are on and some of the dermatologic conditions, but primarily common garden variety gingivitis, bleeding gums, sensitive gum tissue is caused by bacteria. Periodontitis is the combination then of inflammation that's caused by this bacteria, which will then move on to bone loss. Now, what's interesting here is this. What's interesting is we understand that individuals are genetically predisposed to an inflammatory response. And you know, if you've all had your COVID vaccines, you can probably relate to this. There are some patients that after their second vaccine have an inflammatory response. They run a fever, they get chills, they feel run down, they literally feel sick. That is an inflammatory immune response. That is your immune response kicking in. Well, it's the same with periodontal diseases. You must have bacteria in order to have gingivitis, but not all patients that have gingivitis move on to periodontitis or bone loss. What is responsible for a patient to moving from gingivitis to periodontitis is the inflammatory response and the makeup of the specific bacteria. We understand that as individuals, we are susceptible to certain types of bacteria, and we are genetically predisposed to respond to those certain patterns of bacteria. Bacterial plaque forms something called a biofilm. That's why periodontal disease is not a classic infection. A classic infection is when you get a splinter in your finger, it becomes infected, you take the splinter out, you go on a course of antibiotics, and everything gets better. That's not true with periodontal disease. If that were true, every patient that would come in to my office that I would diagnose with periodontal disease, I would give them a prescription of antibiotics and I'd never see them again. That's not true. The reason is periodontal disease and bacteria is not a classic infection. It forms what's called biofilms. Biofilms are a very specific sort of microecology on their own. When bacteria begin to accumulate, they have two choices. They can either succumb to antibiotics and die, or they can form microscopic colonies and defense structures that insulate them from antibiotics. And these biofilms can not only form locally, they can be transmitted through the vascular system to other more distant places. This is why when you have joint replacements, for example, the orthopedic surgeons will frequently ask me to clear the patient of periodontal disease before they do a joint replacement surgery. Many times my cardiology colleagues will contact me and say, I need to do a cardiac procedure. I need to do stents on this patient. I need to do a bypass. I need you to clear this patient of any periodontal disease before I move forward with my heart surgery. The immune response is what constitutes and participates in bone loss and periodontitis. When our immune response kicks in gear, its goal is to protect the host, to protect you. And that's why you get a fever, that's why you feel lethargic. But unfortunately, that immune response not only protects the host, it actually damages, if you will, the host to a certain degree. So if an individual has a highly responsive immune response to the bacteria, based on the genetic predisposition for that immune response, you will have bone loss around your teeth. And that is why we can see advanced bone loss around very young patients. We can see literally no bone loss around very elderly patients that have chronic inflammation in their gum tissue. Or we see the very frustrating patient who comes in, does everything they can do to keep their teeth clean, keeps their dental appointment, maintains their maintenance program in my office with my periodontal hygienist, and we still have difficulty managing their disease. Why? It's not because their treatment is inadequate or that they're at fault of not doing their maintenance themselves. It's because their immune system is highly susceptible to whatever bacterial forms that they have, and they become very difficult to control. That is why we have now cardiovascular disease, diabetes, and rheumatoid arthritis. All of these are now classified as chronic inflammatory diseases. And in order to resolve and control periodontal disease, cardiovascular disease, and diabetes, there is a significant aspect of the ability to resolve inflammation in those diseases. And that's where we're really headed to. Periodontists and dentists, for that matter, have been so focused on bacteria and bacterial plaque. Brush your teeth twice a day, brush your teeth 3 times a day, see your dentist every 6 months, see your periodontist every 3 months. We've put, I believe, too much emphasis, or not enough emphasis, I should say, not enough emphasis on the genetic predisposition for inflammation and the lack of ability of some patients to actually resolve that inflammation. Resolution of inflammation is an active process in the body. Now, one of the interesting aspects, if you start to balance the bacterial aspect of periodontal disease and systemic aspect of disease, there have been several publications that looked at specimens in endarterectomy specimens from carotid stenosis or carotid cleanouts, and over 80% of them were positive for periodontal pathogens. Well, how can that possibly be? We've also seen evidence that periodontal organisms, mainly actinomycetes and something called Porphyromonas gingivalis, which are very specific for periodontitis, have been cultured from atherosclerotic plaques in coronary arteries. Well, remember what we said, that periodontal bacteria and periodontal colonization is a very unique form of infection. It forms biofilms, and those biofilms can travel and become established in different parts of the body, including joints, heart stents, carotid arteries, and really inside your coronary arteries. The significance of that is when you have those biofilms that become established within those tissues, what do? They set off an inflammatory response. They set off an inflammatory condition. And inflammation precludes atherosclerosis. Inflammation is always associated with hardening of the arteries, if you will. So what are we talking about in terms of the prevalence of periodontitis? Well, this was done by the CDC, and the CDC periodically monitors chronic diseases in the United States. And very recently, approximately 5 years ago, they did a comprehensive evaluation of periodontitis in adults greater than the age of 30 in the United States. Thousands and thousands of patients were examined, and they determined that some form of periodontitis was present in adults in almost half of the adult population in the United States. Most of it was moderate periodontitis, and they classified these patients, even if they had one site around one tooth of periodontitis, they were classified as having periodontitis. And what you need to understand is periodontitis is the type of disease that can affect one site around one tooth or many sites around many teeth. What's interesting, as patients age, what we will find is that when patients are 65 years and over, the incidence of periodontitis rises from around 47% to over 70% of the population. If you look at whether they have severe bone loss, moderate bone loss, or mild bone loss, most of these patients have moderate bone loss. We find that the number of patients that have severe bone loss stays relatively stable around 10% throughout life, which really is a key point for me, because as we talk about how this affects other systemic diseases, you will see that the patients that have the most severe disease in terms of cardiac disease, rheumatoid arthritis, diabetes that's difficult to control, they are really the minority of patients, but it's the majority of patients that have moderate disease. So let's kind of look at where we've been and where we've come to. So in 1900, I probably would not be giving you this presentation because I'd be dead. The average life expectancy in 1900, believe it or not, was under 50 years of age. That's why in the 30s, Social Security was in such great shape, because most patients were not alive by the time they reached 65. We died of three things. We died of pneumonia, tuberculosis, and dysentery. We essentially died of acute infection. Now, this is from 2000, and it hasn't actually changed much. In 2000, the life expectancy in the United States is approaching 80. So a significant increase in longevity in life. But now we're dying differently. We're dying of heart disease, cancer, and stroke. Really, what has occurred now is we've gone from dying at a comparatively young age of infectious disease to dying at an older age from chronic inflammatory disease. And to show you how this is playing out, if we step away from periodontitis for a moment and we look at heart disease trends, it's interesting to me that 40% of patients experience a cardiovascular event do not have the common risk factors that you see flash up on the screen. We know that atherosclerotic changes, or what we would term hardening of the arteries, are partly dependent on a long-term inflammatory response. And your body produces certain chemicals called inflammatory mediators that respond to certain challenges in the body. Initially, we looked at essentially three of them. One of those is C-reactive protein. And one of the things that now in a common cardiology examination in terms of preventive cardiology is the measurement of high sensitive C-reactive protein in patients. It's a measurement of the level of this inflammatory mediator that patients produce. There's also something coming on board called interleukin-6, which is one of many inflammatory mediators or many inflammatory chemicals that your body's immune system produces in an effort to address a certain challenge, but at the same time damages the host there are a number of interleukins out there, and this one, interleukin 6, has been implicated in chronic heart disease, and something called TNF, or tumor necrosis factor, which we won't really get into at this point. So we understand that the level of these inflammatory mediators are an indication of cardiovascular health, and that these inflammatory mediators can be produced in a number of body systems, including the periodontium. Because remember, once we get into periodontitis, and once we get into this connective tissue portion or compartment of the tissues that attach to the tooth root, we now set off a chain of inflammatory responses that are genetically predisposed, and the biofilms that are established within that environment begin to increase the level of these inflammatory mediators, or these inflammatory chemicals, not only in the periodontium, but also in distant parts of the body as well, including the cardiovascular system. So we understand that the presence and concentration of inflammatory mediators, or the inflammatory chemicals that you produce or are genetically predisposed to produce, such as interleukins, C-reactive protein is a big one now, and tumor necrosis factors, are measurable indicators of a patient's health. So if you look at that, this is a really interesting investigation. So in the New England Journal of Medicine some years ago, they looked at this marker, C-reactive protein, and other markers of inflammation in predicting cardiovascular disease in women. So they looked at women who had high levels of this inflammatory chemical, CRP, but low levels of LDL, what's called the bad cholesterol. But they determined that even if they had low levels of bad cholesterol, but high levels of producing their innate inflammatory mediator, CRP, they actually had a higher risk than those individuals that had low levels of CRP and high levels of the bad cholesterol, which totally changes our paradigm. So we've been focused on levels of cholesterol to the point of obsession. And yet we have evidence that's showing that if you have high levels of inflammatory mediators, that many of which are genetically predisposed to producing, that even if you have low levels of bad cholesterol, you're still at a higher risk. So increasing levels of this inflammatory mediator called CRP increase the risk of cardiovascular events for all levels of cholesterol, estimated at a 10-year risk. And we're going to get into this a little more because it's really an interesting story that's evolving. So if we say that the presence and concentrations of these inflammatory mediators, which we're learning more and more about, are measures and indicators of patient health, if your mouth has periodontal disease that's untreated, or your arteries are blocked and creating coronary heart disease, tests will show that you have the same inflammatory markers. In fact, aggressive periodontitis has shown itself to be associated not only with the same risk factors, such as smoking, and smoking is a big, big risk factor, not only in periodontal disease, but in heart disease as well. It shares the same genetic predisposition with heart disease that is a leading cause of death worldwide. This is published in a journal on genetics, not on a journal on dentistry. We're talking about periodontal disease and atherosclerotic vascular diseases. And some of the more recent studies look at evidence of supporting an independent association. And we understand that there's observational studies that support the association, which is independent of other factors. However, we must remember that there's a lack of interventional studies, which means that if I treat your periodontal disease, is your heart going to get better? So I cannot sit here and tell you floss or die. that's not evidence-based at this point. But we do know that periodontal interventions and periodontal treatment do result in the reduction of systemic inflammation, and the function of your coronary arteries is enhanced. So what we can say, based on the question that we had earlier, what can we do to decrease systemic inflammation? The first line I would tell you is have a healthy periodontium. That's one of your best aspects of it. But more evidence is really needed to show that prevention can actually modify cardiac outcomes. So we're talking about high sensitivity C-reactive protein. What's a normal level, and what should I be looking for? Well, less than 1 milligram per liter in your blood is considered a low cardiovascular risk. 1 milligram to 3 milligrams per liter in your blood is considered an average risk. And if you have greater than 3 milligrams per liter in your blood, that's measured with a common blood test, you're considered high risk. So 1 to 3 and 3, those are your markers for this. Very, very simple. In fact, the association between this whole concept of systemic inflammation and periodontal disease has been so well studied that there was a joint editorial from the editor of the American Journal of Cardiology and the Journal of Periodontology on a consensus. And here's what they said. They said patients with moderate to severe periodontitis should be informed that they are at increased risk for cardiovascular disease. Why? Because we know that they have an increased inflammatory response. Patients with periodontal disease and one risk factor for cardiovascular disease should have a medical evaluation, if not current, within 12 months. So if you're a patient that has periodontal disease and smokes, I'm going to send you to your physician for an evaluation if you haven't already had one. Patients with periodontal disease and cardiac risk should have a cardiac risk assessment. And there is something called a Reynolds risk score. You can pull it up online. A Reynolds risk score, you'll be asked to impart certain information, such as your cholesterol levels, your CRP levels, your age, your other factors. If one of your parents had cardiovascular event before the age of 60, and you will get a risk score of what your 10-year outlook looks like. Patients with a history of periodontitis and cardiovascular disease should be managed by periodontists and cardiologists in close collaboration. And it's really interesting. Dr. Francis, Bob Francis, was a cardiologist for years at St. Jude. And he and I would have these discussions many times. And Bob, much to his credit, would literally refer patients to me and said, hey, I'm having problems controlling this patient. Can you take a look at him? And he and I worked really in close collaboration, and I really enjoyed our working relationship in those years. And now we're seeing cardiovascular surgeons and cardiologists reaching out to us and asking us to assess these periodontal patients. So let's turn a little bit to diabetes, and what does periodontal disease have to do with diabetes? Well, we know that diabetes is a staggering problem in the United States. 30% of the United States population is estimated to have either diabetes or prediabetes. We also know that the latest data indicates that adolescents moving to type 2 diabetes, which we used to call adult onset diabetes, is increasing at a logarithmic scale, as is obesity in this country, because kids are on this 19 hours a day, their phones, instead of going outside and instead of going to do activities, and their consumption of sugars and refined carbohydrates have skyrocketed. And as a result, we have an obesity problem in this country. we know that of those patients that have been diagnosed as diabetic, 1 in 4 don't know it. So as a periodontist, if I know that 30% of my patients walking through the door are either pre-diabetic or diabetic, and that of those that are diabetic don't even know that they're diabetic, I'm going to have a problem controlling their periodontal disease. So you're looking at approximately 29 million patients that are in that category, and nearly 1 in 3 patients are pre-diabetic, but 9 out of 10 do not know that they are pre-diabetic. So if you have the thought that this may be some fantasy or some presumption, take a look at this study. This was done and it's published in the Journal of the American Dental Association, and it was periodontists that were screening for diabetes in dental practices. And they looked at over 1,000 patients, and they were screened with what's called A1C, or hemoglobin A1C. It's a blood test for diabetic levels, and the Diabetes Association Diabetes Risk Test. This is how they were screened. They were 45 years and older, and almost 41% of them had levels of A1C 5.7 or higher and were referred. Of those patients that were referred for additional testing, 12% of them were diagnosed as having overt diabetes, and 23% of them were diagnosed as pre-diabetes. So this goes along very well and conforms very well with the numbers that the American Diabetes Association is telling us, is that 35% of the United States population is either pre-diabetic or diabetic, and those patients are walking into the dental office. 64% had no disease. So what we understand is that chronic subclinical whole body inflammation is part of insulin resistance. There's a positive correlation between CRP and insulin resistance. As your CRP levels go up, as your systemic inflammatory mediators go up, you become more resistant to insulin. And adipose tissue, that's sort of mid-stomach, sort of beer belly body fat, that we used to think was just an inert storage of fat, just an inert storage of lipids, and that it just meant that you're eating too much. We now know that that is an active endocrine organ that actually produces another inflammatory mediator that will enhance the inflammatory process. And that's why we believe that obese patients are more at risk for diabetes, more at risk for cardiovascular disease, and indeed more at risk for periodontitis, because they have an inert production of inflammation. So one of the most positive things you could do to lower your CRP, besides having a healthy mouth, is lose weight, lose the body fat. There is a positive correlation between those two. We know that adipose tissue is active, and that type 2 diabetes doubles the risk of periodontitis and increases the risk of cardiovascular disease by a factor of 4. So diabetes goes hand in hand in this country with the increase in periodontitis and the increase in cardiovascular disease, all chronic inflammatory diseases of aging. So low level of chronic inflammation makes all of these diseases more difficult to control. And one of the questions that I most often answer of patients that come in that are referred by their dentist, they would sit there and ask me, how can I have periodontal disease? I go to my dentist every 6 months. Why didn't they catch this earlier? Well, it's not just your dentist. It's the aspects of low-level chronic inflammation. And then I started asking them, well, are you on any medications? Yeah, I'm on a statin I'm on blood pressure medication, I'm on metformin for my diabetes, and I smoke a half a pack of cigarettes a day. Okay, well, with those co-founders, with those complications, yes, it's going to be more difficult to control your periodontitis. And at this point, physicians, what they will do is just increase the number and types of medications that you're on. But again, my message to you is be stewards of your own health, eat healthy and exercise regularly, and avoid excess alcohol and smoking, and those inflammatory mediators will begin to go down. That causes us then to rethink periodontal diseases. It causes us to look at bacteria and biofilms. It's not just strictly a bacterial disease, it's the formation of these complex little micro environments called biofilms. And there are multiple bacteria with different bacterial patterns, so it's not a classic infection. And in fact, we can test with literally a saliva test, we can look at what different patterns of bacteria you have. And we can segregate those patterns into high-risk patterns, moderate-risk patterns, and low-risk patterns. And I can tell patients, look, you have very, very high-risk pathogens, very aggressive bacterial biofilms. I not even need to do root planing. I need to put you on a specific antibiotic. And based on the bacterial patterns, I can tell also what antibiotic would be most effective. But in addition to that, we can now genetically test to see what type of genetic inflammatory producer you are. We understand that interleukin-1 is an inflammatory mediator, one of the chemicals that your body innately produces. If you are a high interleukin-1 producer, you will have a higher incidence of periodontitis. And it's not just an incidence marker. It is also a severity marker. So the story goes like this. You can have a bacterial challenge. And if you're genotype negative, if you don't have this gene that's responsible for producing high amounts or overproducing this particular inflammatory mediator called interleukin-1, you may get periodontal disease, but it may be early or moderate. But if you are an individual that genetically is genotype positive, you have the genetics that produces high levels of inflammatory mediators such as interleukin-1 that responds to a bacterial challenge, you may not only get periodontal disease, you will get severe periodontal disease that is more difficult to control. So what are the implications of this genetics now? The genetics technology in the management of periodontal diseases is now across multiple aspects of medicine. There are multiple different genetic forms of adult periodontitis, and chronic periodontitis, up to 50% of susceptibility may indeed be due to genetic factors, not just because your dentist didn't find it. Environment, smoking, and the inflammatory response, combined with the local factors of bacteria, may affect how this disease is expressed and how this disease progresses. And that essentially really is the message of the periosystemic link. I want to talk about something now that really goes along with the genetic inflammatory predisposition. What we're concerned about is pro-inflammatory mediators that are not only pro-inflammatory, they're thrombotic, meaning they promote blood clotting, and they're atherosclerotic, which means they promote changes in the arterial walls. Now, high sensitivity CRP levels can be influenced indeed by diet and lifestyle. There's also another inflammatory mediator called LPLA2. This is a blood test that your physician can take, and it's an indication of the inflammatory activity in your coronary arteries specifically. This can also be influenced by diet and lifestyle. But there's something that's gaining now a resurgence. We've known about something called lipoprotein little a, LP little a, that's what it's called. And we've known about this since the early 2000s. Actually before, I stand corrected, earlier than that. It's an independent factor in terms of early cardiovascular events. And it's independent of diet and lifestyle. You cannot affect this by eating a healthy diet or exercising. It is a genetic predisposition, and it's quite common in the population. It's estimated that approximately 25% of the population has LP little a levels that are high. And it is implicated as an independent factor of a cardiovascular event. And many of you may remember a tennis player, Arthur Ashe. Arthur Ashe had his heart attack, I believe, at 36 or 39. It turns out that Arthur Ashe had a very high level of lipoprotein little a. The next person that you may be familiar with is a fitness advocate named Bob Harper. Bob Harper was the fitness guru and coach in The Biggest Loser. He had his heart attack at 52. So who would have thought that these two people would have heart attacks, massive heart attacks at such an early age? We now know that both of those individuals had high levels of lipoprotein A. They were never really treated for that because there is no treatment. There is, at this date, no evidence-based tested treatment for lipoprotein little a. So what physicians have done is focused on things that they can affect, such as LDL, the bad cholesterol. Well, here's the problem. LDL, bad cholesterol, is made up of essentially two big factors. LDL, the bad cholesterol, is made up of LDL-C, but 30% of it is made up of lipoprotein little a. And you can't affect lipoprotein little a with statins. So I just had a conversation with a cardiologist, a friend of mine, and I said, well, what happens, what do you look for? I kind of baited him a little bit. I said, do you ever have patients that are resistant to statins? You put them on statins and their LDL does not go down. He goes, absolutely, I do. And he said, and those patients are two camps. One population is not compliant with taking their medication, and the other portion of that population are patients that have high levels of lipoprotein little a because statins do not affect lipoprotein little a. We won't go through this as much, but one of the best things that patients can do is aspirin, low dose aspirin, and your cardiologist will recommend that. And you know, when I ask patients why are they on aspirin, they say, well, it's to thin my blood. That's not quite the whole story. Aspirin is a very potent anti-inflammatory. And remember, this lipoprotein little a that you cannot control does three things. It's inflammatory, pro-inflammatory, pro-thrombotic, it promotes clotting, and it is atherogenic, meaning it promotes atherosclerosis. The good news on lipoprotein little a is that there is some evidence that it is, number one, less a concern in patients over 65, and it is less a concern if your inflammatory mediators are low, like your C-reactive protein. But indeed, those patients who have early cardiovascular events, many of those patients who have heart attacks in their 30s, 40s, strokes in their 30s, heart attacks in their 50s, many of those patients likely have high levels of lipoprotein(a). And in fact, some of the Reynolds risk score, for example, that we talked about earlier, one of the questions they will ask is that, do you have a mother or father that had a cardiovascular event before the age of 60? Because this lipoprotein(a) is genetic. But now we move, though, in this day and age, to not only targeting lifestyle, not only targeting food and exercise and medication, we're now going to be targeting inflammation. And as this inflammation story evolves, it's becoming much more positive. So we know that there's a significance of living a healthy lifestyle. In periodontitis, difficult to control periodontitis, and in dermatologic conditions such as rosacea, low dose doxycycline is given. Low dose meaning 50 milligrams a day. At 50, doxycycline is an antibiotic. 50 milligrams of doxycycline does not have any antibiotic properties, but what it does have is a pretty significant anti-inflammatory property. So in patients that have difficult to control periodontitis, and I have patients that have moderate to severe periodontitis and they're under 40 years of age, they're on a low dose doxycycline regime, as are patients, for example, that have rosacea, because dermatologists understand that rosacea is not only bacteria, it's also innate inflammation that the body produces that has a contributing factor to rosacea. And look at the rise of a new drug class. They are called monoclonal antibodies. If you look at commercials now, drug commercials now, and you'll see them for psoriasis, you'll see those for eczema, you'll see those for arthritis. The drug name will end in MAB. So whatever the drug name flashes on your screen, the generic drug, if it ends in MAB, that's a monoclonal antibody. And for arthritis, it's OLLI-CSUF, because it targets the inflammatory mediator IL-1B. And what's interesting is, remember, interleukin-1 is also an inflammatory mediator in periodontitis. And that is a genetically determined predisposition for what you produce. And so now there's very strong evidence between periodontitis and rheumatoid arthritis because they share the production of the same inflammatory mediator. Dupixent, interleukin-4. In those patients that have eczema, severe eczema, which is now called atopic dermatitis, and also certain types of asthma, Dupixent is a monoclonal antibody that decreases the production of IL-4, and these patients have phenomenal recoveries and resolution of both their asthma and their eczema. And I'm really happy to report that probably in the next 2 years, there will be a treatment for Lp(a). Right now, there are phase 3 trials going on, and they're headed now by University of San Diego Health Science Center, UC San Diego, I should say. And it's the rise of a new drug class. It's the rise of what's called an antisense drug. That antisense drug shuts down the genetic expression of Lp(a). So we always said, you know, you can't change your genes, but that's changing. As we understand genetic predispositions to certain diseases, we may be able to go in and modify how that certain genetic expression plays out in patients. And an Lp(a), which has essentially been ignored because there's been no treatment, in the next couple of years, I anticipate that we will get what's called an antisense oligonucleotide treatment that will literally shut down that genetic production of Lp(a) by 80% is what they're seeing. Again, it's genetics, genetics, genetics. Look at the most famous person that I can put up, and that's Winston Churchill. He smoked too much, he ate too much, he drank too much, he never exercised, and he lived 91 cantankerous years. And as he aged, he got even more cantankerous because there was the famous quote from Lady Astor to Winston Churchill that said, "Winston, if you were my husband, I would poison your coffee." And Winston replied, "Ma'am, if I were your husband, I should drink it." So he was a very unusual figure in history. How do I know if I have periodontal disease? Well, again, healthy periodontal tissues never bleed. If you bleed after you brush your teeth, it's not a normal occurrence. Chronic bad breath is a sign of infection and inflammation. Your dentist should be doing regular periodontal measurements with a probe, as we showed earlier, and that should occur every time you go in. Bone loss is not a consequence of aging. Changes in your bite. One of the things that happens in advanced periodontal disease and in inflammation is teeth begin to shift, because as the inflammation progresses within the ligament, it literally starts to push teeth out, and you may experience a change in your bite. Changes in gum line or recession. This is a finding that you, again, as we talked about earlier, impossible to have recession without bone loss. And patients with cardiovascular disease, diabetes, and periodontitis are at high risk. And clearly, if you are a cardiovascular patient or have diabetes, you should have a comprehensive periodontal evaluation. What should I be asking my dentist? Do more than 10% of my probing measurements bleed? We have established in the periodontal specialty community that if more than 10% of your probing measurements bleed, you are likely to have advanced or moderate, at least moderate periodontitis. Do I have probing depths equal, I would say equal or greater than 5 millimeters? 5 millimeter probing depths are not normal. So if you have 5 millimeter probing depths or greater, you are not a routine cleaning patient. Are there signs of bone loss on my x-rays? So typically patients will go into their dentist and they'll say, how do my teeth look? Do I have any cavities? The dentist will say no. Well, there are other things that the dentist sees on the x-ray, and that's bone. And you should actually train your dentist and train your dental hygienist that you're interested in bone loss and the stability of bone over time on x-rays. We know that the decay rate in older patients begins to go down, but that the periodontitis incidence in older patients begins to go up. If I have bone loss, tell me, doctor, is it early, moderate, or severe? Let's just not say I have bone loss. It's like saying, well, you have heart disease. Well, what's the level of my heart disease? Am I going to have a heart attack tomorrow, or do I need to lay off eggs? What am I supposed to do? So you cannot know. Again, the message is be stewards of your own health. Be as informed as you can. And the dentist and the hygienist should be very happy to have these discussions with you. If they're not, it's the time to find another professional. Do you think I need to see a periodontist? I ask my internal medicine guy all the time, think I need to see a cardiologist? And one of the things that I get concerned about is my family history. None of my immediate family going back die of cancer. They all die of heart attacks. They all have their heart attacks in their 40s, 50s, and 60s. They're all short, chunky Italians. So if something's going to get me, I know it's going to be my heart. So I want to be very proactive, and I stay active, and I eat a healthy diet, and I watch my weight, and I see a cardiologist for preventive measures. So what should I be doing? Brush twice a day and floss once a day. Really, you cannot, that's really Doing more to help you feel comfortable is fine. I usually brush, midday between patients, but really, if you focus in the morning and in the evening especially, and floss once per day, you're doing a good job. But how do you brush? Well, a minimum of 2 minutes. And one of the things that I will tell my patients, especially my older patients or those who have implants, is I personally love the Sonicare. The Sonicare to me is a great brush. It has a 2-minute timer on it. It'll have you brush, a quarter of the mouth at a time, and you move around. You can get CVS or Costco's, but they're really a great brush. And one of the things, not even if you have periodontitis, but just plaque accumulation without any periodontal disease is a risk in the older population. The reason is that plaque accumulation can affect respiratory outcomes and pneumonia outcomes. And right now, there are several studies looking at those patients that have severe pulmonary consequences and reactions with COVID and oral hygiene, believe it or not, plaque control, because those bacteria can easily be aspirated into the lungs. So it's important to keep your mouth as clean as possible because of respiratory conditions, particularly pneumonia and other inflammatory conditions. If you have a history of periodontal disease, professional maintenance and monitoring is required a minimum of 3 to 4 times per year. Adopt an anti-inflammatory diet in consultation with your MD and your registered dietitian. I do not want to give you professional advice in that regard. I can tell you in my personal space, I still enjoy a steak, but my steak is once a month. I enjoy fish, but it's no more than once per day. And I've increased significantly my diet of whole grains, my diet of leafy greens, which means romaine, collards, Swiss chard, kale, spinach, and brown rice. Moderate daily exercise is important. We're coming to the realization that 30 minutes of moderate exercise is as good for you as you age as 60 minutes of intense exercise. None of us are trying to be Arnold Schwarzenegger here. What we're really trying to do is improve our balance, improve our inflammatory markers. One of the things that you should know is that aerobic exercise is second place in reducing fat to strength training. What aerobic exercise will do for you is decrease your glucose levels. And sugar, refined sugar, is a major killer in this country. I think Americans eat something like 200 pounds of refined sugar a day. So really, if you go in a moderate exercise program, walking in those individuals over 65 years of age is just as good as running a mile. Walk a mile, run a mile, it's going to do you as much good. Strength training, light to moderate weights is an excellent way of burning fat. To burn fat, you have to do an enormous amount of aerobic exercise. And the reason that strength training is important for burning fat is as you build muscle, in order to maintain that muscle, your body automatically starts burning calories just to maintain what you've achieved. Whereas in running or aerobic exercise, you get that initial climb of glucose burn, and then it's just sort of peters out. Replace missing teeth. I can't emphasize that enough. I will tell you, this is only an observational consequence. But after over 30 years of practice and having patients, when I started in practice, my patients were 30, 40, and 50. Then they were 40, 50, and 60. Now they're 70, 80, and 90. And I can't get an appointment with you guys because it's not because I'm too busy, it's because you all are too busy. And that speaks volumes for how you live your healthy lifestyle. But if you don't have stable chewing, if you don't have stable tooth replacements, and I know we didn't have a chance to talk in depth about them today because I think we really focused on what's important. If you have missing teeth and you have removable dentures, either partials or full, if you cannot eat a high protein, high fiber diet, then you're going to revert to the diet that absolutely you ought not have. And that's a high carbohydrate, high fat diet because it's softer and it's easier to chew. What you should be thinking of is a stable dentition, whatever that means. It doesn't mean 32 teeth. I have patients that function very well with 20 teeth. But if you have partials, if you have removable dentures that are unstable, implants, 1 or 2 or 3 implants can help stabilize them so that you can chew the diet that you need to live that healthy lifestyle. And I believe in a healthy lifestyle. I believe in healthy foods. And I'm going to leave you with a photograph of Alaska. One of the healthiest fish you can eat are the high fatty fish, salmon being one of them. And this is my daughter on a fishing trip with me, pulling in a 30-pound king salmon. So I was very proud of her, and we had a great healthy meal that night. So with that, I will entertain any other questions you have, but I really want to thank you for the honor of presenting some thoughts to you. And I really admire your involvement in OLLI and the healthy lifestyle that you all follow is something that I'd like to emulate. So thank you for that.
Yeah.